Increasingly, we're making extra efforts to understand how it is to live with a myeloproliferative neoplasm. And at this meeting, we presented data from a study called the Landmark study, which was performed in several countries outside of America. And at the British meeting, we presented data on almost 300 UK patients with myeloproliferative neoplasms, and they actually formed almost a third of the entire survey. And this was a survey that was done by patients either on paper, with surveys being handed out by their clinicians, or the vast majority of patients did this kind of 25 to 30-minute survey online. And the survey focused on various aspects of patients' life with a myeloproliferative neoplasm. Two different aspects were presented at this meeting. The first one was about collecting their sort of demographics. So we saw what we expected, that generally patients with ET are younger and female, and at the other end of the spectrum, myelofibrosis patients are older and male. But also focused on symptom burden, quality of life, seeing data that we've seen elsewhere, but we haven't really looked at in detail in the UK population. So that about 90%, over 95% actually of patients reported symptoms. Several patients, particularly those with PV, had symptoms lasting over 2 years before the time of diagnosis. So a little clue about maybe thinking about what work we could do about trying to reach an earlier diagnosis and prevent sometimes thrombotic events that might happen at that time. And then also the number of different symptoms that patients suffered. So on average, patients had around 9 different symptoms. But the most prevalent symptom, over 80% of patients across all 3 disease entities, was fatigue, which of course is very difficult to measure and manage in terms of a clinical setting, and highlights really that there's a very large area here of unmet need which we need to move and try to address. On the other hand, newer data, I think, and something that was very striking for me as a physician and part of the steering committee looking at this data, was that while we think of these diseases as diseases of patients aged over 65, when we look at the patients, around 30 to 40% of them are working, either self-employed or fully employed, but a large number of them had to take time off work. So around, we asked patients to think back over the last 7 days, around 10% of them had time off work during that 7-day period, and 30% of them reported absence from work during a year due to their disease. And then also very striking was the fact that many patients had either reduced their hours or taken voluntary redundancy because of these diseases. So again, focusing on economic impact. Around a third of patients reported a moderate to high economic impact, again across all the disease entities, of having an MPN upon their family finances. And then this new word, for me anyway, there's absenteeism. That's not being at work because you're sick. But around a third of patients were reporting that they were at work but felt unwell. And so then asked in a different way, around the patients generally felt that they were only functioning at about 2/3 of capacity because of their illness while at work. So again, something that's triggered me to really think about this for my patients, the impact on them, and to think then particularly probably about fatigue, because I suspect that's the main thing that's driving this, as something that we should really be focusing on in the future. In the second presentation that we made from this so-called Landmark study at this meeting was really focusing on patients and physicians' perception of disease, perception of how we measure symptoms. Do we measure them robustly enough? Is the consultation long enough to discuss symptoms? And there were some really, just a few sound bites for you from that then. First of all, the physicians generally felt they didn't spend enough time, or they didn't have enough time, is probably more accurate, to discuss fully their symptoms with their patients. But on the other hand, well over 70% of patients felt very satisfied with the amount of time the physicians spent discussing their symptoms. So I think probably physicians feeling that they lacked the time, but patients actually being happy with that, which I think is really very important. Another striking aspect when comparing physicians and patients was the goals of therapy. So for physicians, for example, in treating myelofibrosis, a goal of therapy was improve symptoms, improve quality of life, reduce spleen size. But for patients, the overriding goal of therapy, well, aspiration probably, and that's probably where the difference is. The physician might be looking at what we can do, whereas the patient is more aspiration. Their aspiration was they want to slow or delay progression of their disease, which we can completely understand, but again reflects a gap in our current therapies.